Hello, dear followers. Welcome to this live session with SCAT and Professor Badawi. Um, Professor Badawi is going to answer all the questions we have, everything we always wanted to know on botulinum toxin or on fillers and injectables. I'm just going to include Professor Badawi. And then we're going to go live with Professor Badawi for this 1 hour.
Hello, Dr. Emilia. How are you?
Fine, thank you. How are you doing?
Very, very well. Thank you very much. It's a pleasure to be with you. And hopefully you are going to have a very successful and useful hour answering all the questions the attendees are going to have regarding injectables.
Yes, so it's wonderful that you've joined us here, Professor Badawi, and we're really looking forward to learning from you. And I see that there are a lot of people joining right now. Welcome, dear friends. And please just post your questions and we will try and answer all of them in this 1 hour.
It's great to see those people attending, although it's Friday, so it's a holiday here. It's the weekend in the Middle East and Gulf area. So I really appreciate that they joined. However, I would take this opportunity to invite them to join the SCAD as well as members. We really would like to invite everyone from the physicians attending this live broadcast today to become members of the SCAD. SCAD is a non-profit organization. It's a society which is dedicated for education in the field of cosmetic and aesthetic dermatology. And we are providing free membership for postgraduate students and residents of dermatology. And we would love to welcome more members where we are going to do a much better job with more members, active members actually attending our activities and participating actively in the different events we have.
Yes, wonderful. Thank you for mentioning this. And the SCAT really tries on social media to post interesting content. And recently, we also had a very nice online course, which maybe some of the participants this evening also joined. It was an online course on the basics of botulinum toxin, actually. And despite the fact that it was online, my colleagues and I really tried to make it hands-on. And the participants even had homework to do, and we really tried to in that way make it interactive. So the SCAT does offer quite a lot of new courses also online, also in this corona time. So it's not just the physical present at SCAD meetings at the EADV, etc., but workshops and now online workshops.
Actually, we were thinking that this pandemic is going to interrupt our activities completely. However, we realized that there are different ways to deliver science and to deliver education. And one of the unique things SCAD is doing is the education regarding the courses and teaching courses, which were done live on site with you as well and Dr. Peter Viltus before the corona. However, the virtual course, which was last month, it was not less successful. Many people attended and many people had very positive input about that and comments. And actually here I would like also to announce that the next course, which is going to be advanced botulinum toxin injection course, is going to be in January. It's going to be also online. So I think the feedback we got is encouraging us to do another one next month in January, where all the demonstrations are happening with the live training, the discussions, the questions are being answered. And I believe that more participants are able to attend. And I would like also to stress the fact that it is CME accredited. So this is another bonus for those who are not able to travel for the time being till this pandemic is over.
Yes, that's indeed. Thank you for mentioning that. It was very interesting because the course allowed, because it was virtual, allowed participants to join from all over the world. And so we had people from Europe and from the Middle East all joining at the same time. And that was wonderful. And I think this concept of online courses, I think we will continue this in the post-COVID era.
Definitely. I think it's a great thing we learned during the pandemic.
So our first question has come in. Which is better, baby Botox or Botox, Professor Badawi? Let's get started.
Yeah. Actually, I don't know what is baby Botox.
So I think
However,
I think the person means baby Botox means the half a dose of Botox.
Yeah,
so
okay. Let us first start with something more simple. Who needs Botox, and when we say no for Botox? I always say that Botox is used classically for the rejuvenation, for improving the expression lines. However, we have to know what are our limits and when we should know, when we should say no for the patients. So I strongly believe that the human expressions is something unique to the humans. Animals are not having expressions. Humans are having expressions. And if the expressions are within normal, we are not supposed to delete them. We are not supposed to, just get rid of them, because it's normal human character to have normal expressions. When we start to have exaggerated expressions, this is when we need to do something in order to avoid transferring the dynamic wrinkles into static wrinkles. If I have a glabellar frown line and it is dynamic, however, it is so deep to the extent that after some time, this is going to transfer into a static line, which is shown whether I move my glabellar muscles or no. This is when I should use the Botox in order to decrease the intensity of the contraction of the muscles. If the expressions are normal, I personally prefer the normal look, and I don't like to get rid of that. We don't like to see people around us who are having mask face. So this is a concept which we need to agree on, because in the previous 10 or 15 years, there are some patients who addicted Botox, and every 3 or 4 months they go for the Botox because they started to see a little bit of, expression lines. We have to know the limits, and we have to educate them that it's normal to have some expression lines as long as it is within normal. So this is a concept which I just wanted to emphasize. Now, if you are having baby Botox or smaller dose of the Botox, then it is going to work. It is going to decrease the contractility of the muscles instead of abolishing it. So it might work, but at the same time, we have to know that the durability is going to be short. So discussing with patients their objectives and their concerns is allowing us to come up with the appropriate treatment plan for each particular patient, instead of doing a stable and a fixed plan for every single patient.
Yes, and what about the fact, Professor Badawi, that if you do a small Botox or a baby Botox, I think it's really important that the patient expectations are discussed beforehand, because baby Botox, so half the dose of a Botox on the in the forehead, won't last that long. So if someone's expecting to have an effect for 3 to 4 months, they might be disappointed.
Yeah, I totally agree. And you actually touched a very important point, that patient education and communication. Let me emphasize something which is really very important. When we are talking about cosmetic and aesthetic dermatology, it's a different field than the classic medicine. If you have a patient who is coming because they have a neurological problem, or a cardiac problem, or a hepatic problem, or a renal problem, actually they don't have much of a choice. They have to listen to what the physician is telling them, otherwise they will die. The patients coming for cosmetic and aesthetic dermatology, they are coming for psychological relief. They are coming to improve their appearance and improve their psychology. So we have to understand that. We have to understand how to deal with this human being. It's not a patient. It's a person who is not having a disease. They don't feel well about how they look. So sometimes just telling the patient you don't really need anything is the solution.
Yes.
It's very important to be able to deal with the psychology of the patient rather than do what they want. Do you know that 15% of the patients we are seeing in the dermatology practice are having dysmorphophobia, body dysmorphic disorder? 15%.
That's a lot. That's a lot.
That's a lot. And those patients are seeing things which are not existing. They are seeing, when they look at the mirror, they see that their lips are too small, or their nose is too large, or they have too much wrinkles where nothing of that exists. And once we start to entertain them and do what they want, the psychological condition is worsening. So they start to go from one practice to another because they are unhappy with the outcome, and they have a deterioration in their psychological condition. So it's really very important for cosmetic and aesthetic dermatologists and practitioners in general to be able to spot them, and there is a diagnostic criteria about that, and to understand this and try to deviate their attention to something else. Do for them microdermabrasion or very mild chemical peel, but don't do what they want because there is no problem to solve. So communication with the patient, understanding their problems, their motives is very important. In many cases, Dr. Emilia, I'm seeing patients who are having nothing wrong, but they're under the society pressure from her friends. Why you are not doing Botox till now?
Right.
Why didn't you do filler till now? And when I look at her face, she has nothing wrong. Today, I had a patient with this criteria. She's coming and she's asking for Botox, although she doesn't have any expression lines. So I told her, why do you need it? She said, my friends are asking me, why didn't you have Botox till now? I asked her one question. Are your friends looking weird? She said, what do you mean? I said, are they having a lot of Botox and fillers and they are really looking unnatural? She said, yes. I said, they are jealous of you because you look pretty without any issues. So they want you to look like them so that they feel better. Right. So don't listen to them. She was so happy. She was extremely happy, having more self-confidence. I didn't do any procedure for her. I didn't charge her money, but she is my customer for life.
This is an excellent point, because just because we're doing cosmetic dermatology and wanting to treat people, it doesn't mean that you have to do that in all the cases. Yeah. It's that is, we have to really think about what the patient is there for. But sometimes I feel like people coming for baby Botox or small Botox also are those patients whose friends put peer pressure on them and ask them, and that's why they come to us and they say, I want to try it out, just to see, and then they say, just do a small, quantity of Botox. So I tried out, but I think
this is not an uncommon scenario. However, I'll give you two alternatives in order to be able to address this particular situation. Number one, instead of doing the baby Botox, I would do what's called meso Botox, where we can use a dermal roller with a 0.3 to 0.5 millimeter depth, which is allowing the transcutaneous delivery. And we do a mixture of the mesotherapy cocktails with Botox, and then we do it over the face. It's going to give you the same impact very nicely, very gently, very homogeneously. So this is one scenario where if someone wants that. On the other hand, when I have a patient like that, and we agree that they don't have really a good indication for the Botox, I would start talk about rejuvenation, the concept of rejuvenation, and instead of having a temporary fix. When someone doesn't have a real indication for Botox, I would start to explain to them the process of skin aging, the pathogenesis of skin aging, and the changes happening on the different layers of the skin, whether it's the epidermis, the dermis, or the subcutaneous fat and tissue, and how the structural changes would occur and would impact the functions, which is going to be reflected on the appearance of the skin. And then we'll tell them, let us do something different than what you are requesting. You wanted some Botox to decrease some expression lines. Let us forget about that. Let us repair the epidermis, because when you have epidermal structural defects, then there is transepidermal water loss, and this is going to impact the skin elasticity. So we're going to have less smooth skin. You're going to have large pores and fine lines and wrinkles. If we restore the epidermal barrier function, the hydration of the skin is going to improve. So the elasticity will improve and the skin is going to be smoother. It's going to be with smaller pores and the fine lines will go away. When we start to work on the dermis, which has lost the collagen, excuse me, then we are going to improve the static wrinkles. When the skin is well hydrated, if you really need Botox at that time, it's going to be with longer durability. So let us work on the rejuvenation of the skin and then use whatever you want from materials and injectables from out of body. This is a much better approach, much more natural and longer lasting. So this is a philosophy where, as physicians, we are supposed to be really physicians, looking at the scientific basis and the pathogenesis, and then study our tools, select the right tool for the right indication. In this case, we are going to be delivering a much better result.
Yes, thank you. So, and just a question about the mesobotox you mentioned. So what
Yes.
you say you mix, you do a mixture. So what you mix exactly?
Yeah. In the mesobotox, we get those mesotherapy cocktails, which are having hyaluronic acid and some vitamins used in the injection of mesotherapy. Even some of the fillers companies are having a non-cross-linked hyaluronic acid, which is used as mesotherapy. So we can use one of them. And then I apply something like 40 units of Botox on that mixture. We mix them well. And then we do it with the derma roller. We just do the derma roller with the 0.3, 0.5, or if there is indication for collagen induction therapy, we can use the deeper needle derma roller or derma pen. And then we apply this cocktail on the skin and massage it in. It is going to have an outstanding results. However, it's temporary. You know, it's not going to be long lasting. So it's very important to communicate that with the patients so that they have realistic expectations. This is the mesobotox. And it's working very well. One of the nice indications which I would like to emphasize also is the hyperhidrosis. If someone is having hyperhidrosis, especially in the forehead or on the face, then we can use the Botox by itself without mesobotox. And then we do the derma roller. The 40 units are going to be diluted over 2.5 cc saline, and then it's going to be distributed in the areas of hyperhidrosis, and it gives very, very nice results.
Interesting. Thank you for this insight. So we have another question coming in. Bushra Kazem is asking, what is the appropriate dilution of Botox for the face hyperhidrosis?
Okay. Now, face hyperhidrosis and the hyperhidrosis?
Well, I read dilution of Botox for face hyperhidrosis. So it's a bit what you just touched on. You touched on mesobotox, but maybe this person is asking, generally speaking, for facial hyperhidrosis.
Dr. Bushra is a dear colleague of mine, and I would like to thank her for joining us today. Now, in general, when I'm using the Botox for a particular muscles, I prefer to use it with lower dilution. I mean, on 1 cc. I dilute the 100 units of botulinum toxin on 1 cc, the Botox I'm talking about. So I'm more precise. I'm avoiding the diffusion. So the effect is more concentrated, more precise, and I'm very happy with that. When the effect is required to be diluted or diffused, like in case of hyperhidrosis, then I prefer to do it as mesobotox, better than injection, because it's going to be diffused much better. So I use a dilution of 2.5 cc saline on the 100 unit, and then I use something like half 50 units of Botox, and I do apply them after the derma pen or the derma roller on the areas of hyperhidrosis, whether it's the forehead or the cheeks or wherever the hyperhidrosis is. I do the derma pen or the derma roller with a small needle, 0.3 to 0.5, and then I apply the solution on the skin, massage it in so that it's absorbed, and then it gives very nice result about 3 months. Now, my advice regarding this, Dr. Bushra, is that I prefer to do that just in the beginning of the summer, because this hyperhidrosis is going to be much less in the winter. So if we do it just before the summer or with the beginning of the summer, then it is going to cover most of the summer, and then you don't need to repeat it that much. When the winter comes, there is no need to do that. So it is solving the problem. In this case, we are going to do it once or twice per year. Everyone is happy. Very simple, small procedure, and it is serving the purpose.
Thank you. I hope Dr. Bushra is satisfied with this response. Question coming in, whether mesobotox can be under the eye wrinkles and the smoker lines.
Yeah, of course, we can use it anywhere, and it's going to be a very nice alternative to other things. However, it's going to work on only the superficial, fine, dynamic wrinkles and lines. If there are static wrinkles, then my suggestion is to do the derma pen or the derma roll with a longer needle, so 1.5 ml, so that we get some collagen stimulation. And then we apply the mesobotox. Is going to do both the effects, get rid of the fine dynamic wrinkles, and also with the collagen stimulation, we are going to improve also the static wrinkles. If we are talking about tear trough, then the mesobotox is not going to help. In this case, I would recommend to do the PRP gel, so that we are doing a filler-like effect, and then the mesobotox is going to improve only the superficial layers of the skin.
Right. So basically, you're saying don't do mesobotox in the tear trough. So for the eye wrinkles, do PRP in that case, and
PRP gel.
Pardon? Gel.
PRP gel.
Gel. And
with the PRP gel, it has viscosity, so we can do a filler-like effect.
Oh, wonderful. And you also use the derma roller or derma pen for the PRP gel?
No, we do the injection so that we are filling the areas which we need. And then when you are preparing the PRP gel, some of the plasma is going to be prepared as gel, and you are going to have 1 or 2 tubes which are going to be used without the gel, which can be used then later on after the derma roll as topical mesotherapy or whatever. If you have some dynamic superficial wrinkles, then you can add some maybe 40 units of Botox on that mixture of the PRP, and then you can apply it as mesobotox.
Right. And so what you were saying about this other areas, for example, the smokers lines, that would be a good area for the combination of mesobotox together with the collagen. I think that would be beautiful for the area around the mouth, right?
Yes, definitely.
And how long are the effects, Professor? If you do, for example, the area around the mouth, the smokers lines, with this mesobotox combined with collagen, how long do the effects last for?
Usually it's going to last at least for 3 months, which is great. However, here again, I would like to emphasize that it is very important to avoid having telescopic vision. If someone is coming to complain of smoker's line, where is the pathology, Dr. Emilia?
Well, it's
in which layer of the skin? No, I mean, is it in the epidermis, the dermis, or the subcutaneous tissue?
Well, if it depends on the how superficial they are, right? So if it's sometimes you see that it's epidermal, and sometimes you do see that people have lost collagen. So we're talking more about the dermal pathology.
When we talk about smoker's line, then the pathology is definitely in the dermis where collagen has been lost. However, when we have someone who's having smoker's line and some sort of chrono-aging, then there is also a degree of photoaging in this area. And photoaging means that the epidermis is disturbed. We have hyperkeratosis. So it is really very important to pay attention to the improvement of the epidermis and restoration of the epidermal barrier function with whatever modalities we have before or with, along with improving the dermis, stimulating the collagen. It's really very important to improve the epidermal barrier function, because only then we are going to have better hydration of the skin. And if we have better hydration of the skin, then the durability of anything we do and perform in the dermis is going to be longer term.
Right, that's very clear. Thank you. So then there's another question about what is the solution for a sagging face? So I guess it means a face where, you know, the vector is no longer a V vector, but this shape.
Yeah.
And the question is the solution for the sagging face filler or ND-YAG laser is the specific question of this colleague,
yeah.
Dr. Rosti. Thank you, Dr. Rosti, for the question.
Very interesting question. Who knows me knows that I'm very much inclined into rejuvenation instead of temporary fix. When I'm using filler, which is a foreign material for the body, then this is not called rejuvenation. This is called temporary fix. We are doing something to give us immediate improvement, but it does not improve the structure of the tissue. If I'm able to use energy-based devices in order to tighten the skin from within, in order to rebuild the collagen, then I'm improving the structure and the function of the skin, which is going to be 1, more natural, 2, longer term, 3, stopping the process of aging or reverting the process of aging. So I would always be more inclined towards improving the skin from within and then retouch with any materials from outside, whether it's fillers or Botox or whatever. Even threads. Threads are going to give me an immediate effect. However, it's a foreign body where it's going to stimulate some fibrosis around. So from my point of view, it's not the ideal scenario unless we fail all the other natural ways to improve the skin. So I'm using the ND-YAG with special long pulse in order to tighten the skin. And then I convert the pulse into a shorter pulse in order to stimulate the collagen. And before that, I work on the epidermis with something which can improve the epidermis, like microdermabrasion or similar techniques. And in this case, I'm treating each layer of the skin with the appropriate technology to achieve rejuvenation, restoration of the structure and the function of the skin.
Right. And what would be your order? So this colleague has asked fillers and ND-YAG. So which order would you do? Would you first do the energy-based devices and then afterwards go into injectables? How would you go about it?
With no doubt. I always prefer to use the energy-based devices because I need to improve the structure. And after that, if the structural improvement is not satisfactory, then I complement what I did with anything from outside the body, whether it's fillers or Botox or whatever. In this case, the amount of materials I'm using from outside the body is going to be, number 1, less. Number 3, it is going to be injected in a more healthy structure, more healthy skin. So it's going to be looking more natural and it's going to be longer lasting. If I improve the epidermal barrier function and after that I inject fillers, then the skin is well hydrated and it is going to stay in the tissue much longer than if the tissue and the skin is dehydrated, and then it's going to, you know, consume a lot of water instead of plumbing the fillers and giving it its natural volume.
Right. Thank you so much. And how long do you wait after the treatment with energy-based devices? I guess it depends also whether you're working ablative or non-ablative, but how long would you wait?
Yeah. Now, what I would do is to do a course of whatever I'm doing to improve the skin. For example, if I'm doing microdermabrasion to improve the epidermis, I need 4 sessions on weekly interval. If I'm doing the ND-YAG laser to rejuvenate the skin and stimulate the collagen, I do 3 sessions on monthly interval. And then the skin is going to continue to improve for 6 months, because after we use the laser, we are going to have new collagen deposited into the skin within 3 weeks. However, this is immature collagen. It's not fully functional. It needs to mature from collagen type 3 to collagen type 1, a process which takes about 6 months to happen. And after that, I prefer to inject the fillers or the Botox and so on. However, this might not be very satisfactory for patients who would like to have faster effect. So if someone is eager to get injected with fillers, and I'm seeing that on daily basis, I can do the filler injection or the Botox injection 1 or 2 days after the non-ablative procedures. If I'm doing ablative procedure, we have to wait till the complete healing of the skin, and then we can inject the fillers or the Botox. But it is not the vice versa. If someone injected fillers, it is very important to wait for 3 weeks before we start to do anything for the skin. Otherwise, the procedure I'm doing from the energy-based devices is going to dissolve the filler faster. If I inject Botox, I have to wait for 2 weeks before I touch the skin, so that I make sure that I got the maximum effect of Botox, and then I do whatever energy-based devices I need to do.
Wonderful. These are very practical tips. I hope that our followers can really start using these tips in their practice. So we also have a question, whether we can mix meso and Botox in the same syringe.
Yeah, usually I do mix the Botox with the dilution I need. And then I do mix the mesotherapy in whatever, if it is ready or if I prepare it. And then I do the Botox, I put it with the same syringe of the mesotherapy, and then we have the mesobotox. And this is what's going to be applied on the skin after doing the dermapen or the derma roller or whatever it is.
So it can be mixed into this in the same syringe. Doesn't need to be injected or applied.
Yeah, we are going to be doing the derma roll, and then with the syringe without the needle, we start to put a drop by drop on the surface of the skin, where when we are doing the dermapen or the derma roll, it's going to be diffused into the skin. Right. So yeah.
Wonderful. And then there's another question of whether we can use plasma gel as a lip filler.
Yeah, we can do that. However, we have to communicate with the patient that it is not going to be like the filler. It is going to be giving some plumbing effect. It's not going to be as durable as the filler. The filler is going to stay for months. However, on the other side, the good side is that although it's not durable, it has growth factors. So ultimately, although it's going to go down a little bit, but the collagen synthesis and the collagen stimulation is going to give you a very natural look, and it's going to be giving a longer durability than the fillers, which can give a little bit of a weird shape for the lips. And sometimes we have some, granulomatous reactions or fibrosis or whatever. And if there is overcorrection, then it needs to be resolved. So I personally prefer that the PRP gel is used than the fillers.
Right, so that's very clear. And back to this mesobotox, I think everybody's really excited about this. So I see a lot of comments coming in concerning this. So you might have mentioned it, but let's just make it more explicit. How long does the effect of mesobotox last? This is, Sama El Salini is asking this question. How long does the effect of mesobotox last? And I guess it depends on the product, right? So.
Yeah, Dr. Samah is a very active dermatologist from Libya. So I would like to welcome her and thank her for joining today, although it's Friday. As I mentioned, the mesobotox would work for maybe 2 months, 3 months, up to 5-6 months, depending on how healthy the skin is. So that's why if we are able to work on the skin and make it more healthy, the effect might stay for 6 months. If the skin is dehydrated and having hyperkeratosis with poor collagen content, maybe it's going to last for 1 or 2 months. So all depends on how healthy the skin is. And that's why I encourage all the colleagues who are attending today to work on the restoration of the skin health. Work on the different layers of the skin to restore its structure and function. And in this case, whatever you're using from outside the body it's going to be lasting longer and looking much more natural.
Great. And is this it? So, someone else, Manar Salam, is asking, for facial hyperhidrosis, how long does the effect last? Is this the same as the mesobotox?
Yeah. Dr. Manar, welcome to the live broadcast. Thank you for your active participation. Usually the hyperhidrosis treatment is going to stay for 2 or 3 months. And that's why I prefer to do it in the beginning of the summer, so that after 3 months, you can do it once again, and then the winter is coming. In the winter, you don't need that too much, so you are going to do it 2 per year, and this is going to be making everyone's life much easier, and they are going to be happy.
And then there's also a question here whether you can inject the mix. And I think the mix thing, Eman Mekavi means the mix of mesobotox with or meso with Botox. I think you responded to this question. You can inject the mix, right?
Yeah, you can inject the mix. However, we have to ask ourselves, why do we need to inject the mix? The mesotherapy in general is being done with the mesotherapy technique, where we are doing the mesotherapy in different areas so that we are distributing it widely. The Botox is going to be, better spread on the skin, because if it is injected for hyperhidrosis, then it is going to be in particular areas, not everywhere. If we are injecting it for certain dynamic wrinkles, then this is the area where we need it. And also doing it as a mesotherapy or massaging it on the skin is going to be more practical. So if you feel as a physician, as a dermatologist, that there is an indication to inject both the mesotherapy and the Botox, then inject it. If you feel that you don't need to inject the Botox only in particular areas, then it's better to be injected. If the pathology is widespread, then it's better to do it in mesobotox technique with dermal needling technique.
Thank you so much. And then we have this other question. Ola Soleiman is asking this question. Welcome, Ola Soleiman. The question is, what are the causes of filler granuloma? So we're talking more now about the complications of fillers.
Yes, filler granulomas happen with immunological reaction of the body. And that's why I'm always saying that whenever we inject a foreign material into our bodies, then we cannot guarantee 100% how our bodies are going to react to that material. I think when we were attending the conferences, every single conference we attend, there is a particular session for complications of fillers. And sometimes we are amazed to see some speakers presenting their cases of complications after 4 or 5 years of injecting hyaluronic acid fillers, which are not permanent, which are supposed to be absorbed within 18 months, maximum 1 year to 18 months. But after 4 or 5 years, sometimes we are having reactions to biofilms or granulomas or whatever. So the patient might have an immunological disorder. The patient might have hypersensitivity. The vehicles of the fillers might have more endotoxins or proteins. So we don't know exactly when we are having a cross-linking reaction in order to put the molecules together so that it's staying longer. This is a biochemical reaction, and we cannot guarantee 100% what are the impurities contained in the filler, which might cause some reactions which we cannot predict.
Yes, and do you think that people with maybe autoimmune disease or other systemic disease on systemic medication, immunosuppressants, what is your experience, Professor? Are these patients who are more prone to develop filler granuloma?
In many cases, we find a strange immunological reaction. So we start some investigations to lead to the diagnosis of one of those autoimmune diseases. So sometimes the patients are not aware they have any disorder, immunological disorder, but after injecting fillers, then they start to have reactions, and we start investigation and then discover that they have one of those diseases. I would like also to highlight the fact that today, with this era, with the COVID area, and starting of the vaccine and the vaccination, which is going to definitely manipulate the immune system of the humans, we might start to see reactions, unexpected reactions in those who are injected with that vaccine. So we have to be careful, and we have to pay attention to anything which is not expected. And that's why I always stress on the fact that whenever we are able to improve the condition of the skin without the use of any materials from outside the body, we are in a much safer position than when we use materials from outside the body.
Right. Yes, this is very valuable information you're giving, and also because of these upcoming vaccinations, to be very cautious. I personally, when people have systemic disease or autoimmune disease, I warn them that there could be a more risk of granuloma, for example, in fillers. So you should be more cautious when you choose your patients. And I think if patients then know what the risks could be, maybe they might rethink the treatment.
Yeah,
I personally don't think that there's so much of an issue with Botox. It's more with fillers where there's
I agree. I totally agree. Yes.
so there's another question about what is the best serum to use with the dermapen. So do you have any advice on that? Which serum would you advise with the dermapen?
Yeah, I mean, I think it is. It depends on what you have, but usually I prefer the mesotherapy serums, which are approved to be injected into the body, so that we have a better safety profile. Sometimes you might have a hyaluronic acid serum, which is not supposed to be injected. This is only for topical application. This is not good. So it's much better to use the cocktails and the serums which are prepared for the mesotherapy and approved for that purpose. Those are safe, and I prefer the hyaluronic acid, which is supposed to improve the hydration of the skin and then nutrition of the cells. So those are the ones which I use, and it depends on what problems we have. Sometimes if someone is having melasma, for example, or hyperpigmentation, then a cocktail or a serum which is having tranexamic acid, and we started to see mesotherapy cocktails which are having tranexamic acid available. So I would select something like that with hyaluronic acid for the hydration and nutrition of the cells. So it depends on what problems we have.
So I can understand the question of this colleague, because there's so much on the market. There's so many different products, How do we know which are the best ones to use? How do we make a selection? Obviously using the ones which are approved, but otherwise it's quite a challenge.
It's very important to make sure that whatever product we are using is having a big company name behind, because then they are going to have certain quality control. If it is a brand name which I never heard about, right, and I would not trust. It is very important to have a product which is going through the correct channels, Ministry of Health approval or whatever approvals in the country I'm practicing at. Otherwise, I wouldn't trust to inject something into the human body.
Yes, I agree. And then there's another question. Maybe it's in the same line, along the same lines. What is the best meso to add to the Botox? Yeah, I think this is. Yeah. Do you have a preference?
Yeah, no, I mean, we have to. There is no one correct answer for everyone. It depends on the problems. If we have something which the patient is having dehydrated skin, then I would use hyaluronic acid. If the patient is having some hyperpigmentation, then I would use something like tranexamic acid, and so on. So the different mesotherapy cocktails are for different problems. So we have to see what are the problems existing, and according to that, we are going to select the right combination to each patient according to what are the problems with upper hand.
Great. So when we go back to the subject of filler granuloma, Dr. Haya Itan also agreed with us. Dr. Haya Itan had seen a SLE patient, so with systemic lupus, with facial granuloma after filler injection, unfortunately,
Yeah.
she says. So that's really, we should really be cautious. And maybe,
Yeah.
I think these are actually, like SLE would be an absolute contraindication
Of
for.
course, of course, definitely. And when we have a patient with granuloma, then as a dermatologist, there is a granuloma. We would like to resolve it. If the injection is recent and we start to see that there is an immunological reaction, we try to dissolve the filler with hyaluronidase. If it is an old thing, then we can use intralesional steroid injection or sometimes even systemic steroids. So it depends on the situation. And here, again, I would say it is really very important for the cosmetic practitioners and the cosmetic dermatologists to be strong dermatologists, because only then they are going to deal with the situation and the complications with their dermatological knowledge. That's why it's really very important that only qualified people are practicing cosmetic dermatology, because other specialties who are thinking that it is easy to inject and easy to to handle the issues with improper knowledge about how to handle granuloma, how to handle post-inflammatory hyperpigmentation, how to handle the vascular accidents with fillers, it is really going to be a big mess.
Right. So yeah, I fully agree with you, and I think that as in any area in medicine, I think you should do treatments in an area where you can also treat the complications. If you
Yes.
cannot treat the complications,
don't do the procedure.
Don't do the procedure, exactly.
Yeah.
And so I hope that Dr. Bushra, that we've answered your question on how to treat the granuloma safely. So Professor Badawi just mentioned hyaluronic acid or intralesional corticosteroids. And I had just another question for you, Professor. Do you use ultrasonography when you want to visualize the granuloma, or just just feel it? Do you palpate it, or do you prefer to do it with the treatment with ultrasonography?
Actually, Dr. Emil, let me highlight this because this is really very important. And again, I would like to encourage all the colleagues who are joining us today to become ESCAD members. And I promise you, as the ESCAD president, that you are not going to regret it. We are going to have a lot of activities for the members, which is going to be very valuable. One of the courses of the ESCAD is going to be educating the attendees about how to use the ultrasonography while injecting fillers, because there are so many nice indications in order to avoid complications and deal with the complications with the ultrasound. And today there is a small handheld ultrasound which can be purchased with any practitioner, and with the proper education we are going to be able to see where are the vessels which we need to avoid while injecting. If there is a granuloma, we can see where it is located, and when we inject intralesional steroid injection, we can be very precise and make sure that we are at the right level. So there are so much nice indications for ultrasonography, and this is going to be one of the missions of the ESCAD, which is going to conduct one or more courses about using the ultrasonography while injecting the fillers and while dealing with complications of fillers. Thank you for raising that point, Dr. Emily.
You're welcome. So, Professor, we have a couple of so people are getting very excited, and there are lots of questions coming in. So I'm just going to try and ask you to answer these.
I'm just afraid that I think the live broadcast is going to end within few minutes, 8 minutes. I think if it is 1 hour, I don't know if they extended the duration.
That's about. I think we have 8 to 10 minutes, but I think we'll manage. So London Beauty Queen, a beautiful name, is asking what your thought is on microneedling technique, which goes very deep on the skin and causes a lot of bleeding, and if that's necessary or if it's traumatizing for the skin.
Okay, let us agree that if you want to increase the transcutaneous delivery of materials, active ingredients, then a needle length of 0.3 to 0.5 is enough. And those are the derma rollers which are being sold in the pharmacies for the patients for home use. So this is just to increase the transcutaneous delivery. If we need collagen induction therapy, then the length of the needle should be above 1 millimeter, 1.5 ml. This is the one used for collagen induction therapy. Now, depending on where you are treating, so if you have a patient who's having coarse, thick skin, you can go up to 2 or 2.5 ml safely without any problem. If you have a patient who is having some scars and fibrosis, then you can go up to 3 millimeter safely. But you don't need to go to 3 millimeter length of a needle in normal skin. There is no point. It is not going to be traumatizing. It's not going to harm. However, there is no need for that because it's going to be more painful. 1.5 ml for collagen induction is enough. If the skin is coarse, then we can go to 2. If there is fibrosis, like acne scars or some scars with fibrosis, then we can go up to 3 or 3.5. So this is the guideline. One last thing I'm going to say, there is nothing called I sterilize the roller or the needles or whatever and use it again, even if it's myself. Because when we roll those needles over the skin, there is wear and tear, and the needle is going to be bent, and it works like a hook. So it can cause some sort of minute fibrosis. So please, this is a disposable. It should be used once and then throw it away. There is no way to sterilize it well. Plus, with the wear and tear, it can damage the skin and cause minute fibrosis.
Thank you. So you're saying, you were mentioning it was millimeters, you're saying.
Yes.
So,
yes.
So yeah, wonderful. So I hope we answered our colleague's question. Then there's another question. After injecting Botox and fillers, when when could you use a moderate chemical peel or inject PRP? So after Botox and fillers, how long do you have to wait before doing the chemical peel?
Yeah.
Or would you do it vice versa, the other way around?
Yeah. In general, I don't inject Botox or fillers on irritated or inflamed skin. This is rule number 1. Rule number 2, if you inject Botox, please wait 2 weeks before you do anything to the skin. If you inject fillers, please wait for 3 weeks before you do anything to the skin. So those are the rules. If you injected PRP, you have to wait for the skin to become calm and normal, no inflammation, no irritation before you do anything else.
And wouldn't you do it the other way around, that you do the chemical peel first, the PRP, see what the result is, and then based on that, and then apply the Botox and filler?
Definitely. This is a much better order. I agree with you.
Okay. And then someone's asking if we can replace the laser by chemical peel and give the same results. So
it depends on which laser are we talking about. If we are talking about the superficial peeling with the laser, then yes, chemical peel can replace that and give you the same result. However, both the techniques are not safe on darker skin types and tanned skin. Both of them need good preparation before the procedure and good skincare after the procedure. Otherwise, you are going to get a marvelous, very nice effect in the beginning, and then you are going to get PIH later on. So it is really very important to prepare the skin well. Whether you use the laser or the chemical peel, it doesn't make a big difference. If we are talking about non-ablative lasers, they don't touch the epidermis. They are going to work on stimulating the collagen, tightening the skin without any effect on the epidermis, unlike the chemical peel, which are working mainly on the epidermis and less effect on tightening of the skin or collagen stimulation. So we have to know what technique are we talking about, and we have to compare apple with apple.
Right. And then there's a question about hyperpigmentation. And in hyperpigmentation, you mentioned that you sometimes use the mesotherapy. Yes. And our colleague, Dr. Eman Mekawi, is asking, why do we put Botox in meso in hyperpigmentation?
No.
It's not necessary. No.
Yeah, no, it's not necessary. No. If the issue is mainly hyperpigmentation, then of course not required. However, I'm saying if we are having multiple problems, like superficial fine wrinkles and hyperpigmentation, large pores, then I can do the mesobotox, so that when we inject when we apply the mesobotox, then it's going to relax the muscles, the pores are going to shrink, and the pigmentation is going to improve. Usually the patient is coming with the most pressing problem, But if we examine the patient well, we are going to realize that this is not the only problem. We have a problem in the epidermis, we have some collagen loss, we have some skin laxity. So we have to design a rejuvenation plan, not just, target what the patient is complaining of.
Yes, so it's very personalized, right?
Yeah.
Then a lot of questions coming in on one more about what's the best procedure to treat wrinkles around the eye?
Okay.
So,
Yeah. This is usually dynamic wrinkles, the crow's feet, and the dynamic wrinkles when we smile below the eye, and those are going to improve by injecting Botox. However, if we have static wrinkles, then it means that there's skin laxity and collagen loss. So in this case, we are doing some procedures around the eye, like the non-ablative Erbe to tighten the skin. I don't like the plasmage because it's caused a lot of hyperpigmentation. It's a very crude technology, so I don't really like it. But when we are using the non-ablative Erbe, it is safe on the periocular area. CO2 also can be used, the fractional CO2. However, the incidence of hyperpigmentation is much higher than the Erbe. And with the CO2, we need intraocular shield in order to avoid any ocular damage. With the Erbe, it's much safer.
thank you. And so the colleague who was asking about the depth of the needles, and you talked about this. This colleague is asking, would you use these different depths on dark skin?
Yeah.
And what's the maximum length of the needle you would use on dark skin?
Actually, the skin color does not have any impact because we are using a technique which is not associated with heat. So when dark skin, we are worried when we are using a technology with heat because it's going to stimulate melanogenesis and hyperpigmentation. But when we are using needles, then it is not associated with heat. We are not worried of hypertrophic scarring or with hyperpigmentation. So the concept is going to be similar whether we are using skin type 1 or skin type 6. There is no difference. So the same principles apply on all skin types.
Interesting, because I would have also thought that if you apply a needle on dark skin, you have more chance of hyperpigmentation post-inflammatory because it's post-inflammatory hyperpigmentation. Is that the case or not?
Yeah, you know what, Emilia, with the needling, the needle channels are closed within 90 minutes. So right. The inflammatory reaction is deeper than that, and we get some fibroblast, acute inflammatory cells, so it's going to synthesize new collagen. And one of the very nice things is that when we are inserting the needles into the skin, it is increasing the negative electrical potential. And this was found to be a very strong stimulation for the regeneration power of the tissue. Plus, it stimulates the microcirculation with more growth factors and nutrients to the area. So it has a really very valid scientific benefits to the skin, and not stimulating the melanogenesis as with the procedures associated with heat.
Right, thank you.
So I'm afraid that the broadcast is going to end soon. So maybe we should wrap up here, and I would like to let everyone know that Emilia is going to save that broadcast on the IGTV of the ESCAD Society Instagram, and if there is a demand, we might have another live Instagram in a couple of weeks or so. Just write to us your questions, and we are going to make sure that we are going to have another live broadcast to answer those questions. And once again, I really wish that all the colleagues who are joining us today are becoming members of the ESCAD. Only then we are going to be a more powerful society, and we'll be able to add value to the society and to the community we are working in.
Yes, so thank you so much, Professor Badawi, for asking all the questions and all we wanted to know. And I just wanted to mention this platform is not only for physicians, this platform can also be used for patients. Yeah. Patients who have questions, who would like to raise their concerns, because the questions patients have are different than those that we have as physicians, but it is also important to know what they also think and want to know about injectables. So please propagate this medium amongst your friends or your patients, and we'll be very happy if there is demand, to increase the number of our live Instagram sessions so we can answer all your questions and concerns.
Yeah, one last thing I would like to announce before we close this broadcast. On 14th of January, there will be a nice Zoom meeting for the members of the SCAD, where it is going to be with the SCAD board, and it is going to be titled Ask Me Anything About Skin Pigmentation. So again, it is going to be a great opportunity. We are going to announce that to the members, and the SCAD board are going to be attending. I'll be moderating that session, so we are going to direct many questions you are going to send as physicians. This is only for physicians on 14th of January, but we are going to be announcing that earlier than the meeting or the Zoom meeting. And I would love to see all of you there on that broadcast. Here on the Instagram, if we felt that there is a need, then we can do another live broadcast in order to answer your questions.
Thank you so much for your time and for answering all the questions we had. Yes, we hope to see you all soon again.
Great. Thank you for your great moderation, Dr. Emilia. It's always an enjoyment to be with you, and hopefully we are going to meet all of us live soon after the era of the corona.
Hopefully, and until then, let's use this these digital ways of learning to learn more about injectables.
Yeah. Okay. Great.
Thank you very much.
Good night, everyone.
Bye-bye. Good night.
Bye.
Bye-bye.
You just need to press the cross on the right of the screen. So
yes.
It's going to end.
Thank you.
And then save and then broadcast on the IGTV.
Thank you so much. Bye-bye, everybody.
Bye.